Welcome to the debate. Today, we are looking at what I consider one of the most daring physiological gambles in modern medicine. We are asking if the human lung, an organ exquisitely designed by evolution to extract oxygen from the air and expel carbon dioxide, can be successfully repurposed as a high-speed express lane for delivering systemic medication.
Right, and it really is a question of biology versus engineering. We are specifically analyzing the case of Afrezza, which is the inhaled insulin powder approved by the FDA back in 2014. And the core tension here is undeniable. Do we prioritize the convenience of a whistle-shaped inhaler, or do we respect the biological reality that the lungs are a delicate filter, not a digestive tract?
I think that framing might be a bit reductive, though I do appreciate the skepticism right out of the gate. The central question we are tackling is whether the unique pharmacokinetic profile of inhaled insulin, its sheer speed and the freedom from needles, is worth the trade-offs. I represent the position that Afrezza is a valid physiologic breakthrough that addresses the massive, often unspoken burden of needle fatigue for people living with diabetes.
And I take the position that we are trying to solve a behavioral problem by creating a new biological one. I am highly skeptical of repurposing a vital organ for convenience, especially when the safety data flashes red lights regarding acute bronchospasm and long-term lung function decline. I mean, when you look at the FDA boxed warning, which is the strongest warning they have to ask, is the powder really worth the puff?
Well, let's start with the argument for the defense then. For decades, the holy grail of insulin therapy has been to match the speed of a healthy human pancreas. When a healthy person eats, say, a bagel, their insulin spikes almost instantly to handle that carbohydrate load.
Right.
But subcutaneous injections, even the modern rapid-acting analogs like Lispro or Aspart, are biologically slow. They sit in the fatty tissue under the skin, waiting to be absorbed into the capillaries, which creates a frustrating lag time. Afrezza is entirely different. It uses Technosphere technology.
Technosphere sounds a bit like marketing speak, but I will admit the chemistry is actually quite interesting.
It is fascinating. It uses a molecule called fumaryl dicopiperazine, or FDKP. Think of these as microscopic carrier particles, almost like a molecular Trojan horse. When you inhale this powder, it lands on the alveolar surface deep in the lungs. Because the pH there is neutral, these particles dissolve instantly. We are talking seconds. The insulin is released and hits the bloodstream immediately.
I will grant you the speed, the pharmacodynamics, which is just the technical term for what the drug does to the body, are stark. In type 1 patients, the insulin peaks in the blood in about 12 to 15 minutes. That is incredibly fast compared to an injection, which might take an hour to reach peak concentration.
Exactly. And just as importantly, it leaves the system fast. It returns to baseline by about 160 minutes. This mimics the body's natural first-phase insulin response beautifully. It creates a sharp peak to handle the meal, and then it is gone. Injections tend to linger for 4 or 5 hours, which can lead to low blood sugar or hypoglycemia long after the meal is over.
But here's where we diverge. You are focusing purely on the result in the blood. I am looking at the journey through the lungs. You are bombarding the alveoli, the microscopic air sacs responsible for keeping us alive, with a foreign powder. The FDA label is not subtle about this. The boxed warning explicitly highlights the risk of acute bronchospasm in patients with chronic lung disease.
Which is why the protocol is very clear. It is contraindicated for those patients. If you have asthma or COPD, you simply do not take it.
But think about the implications of that exclusion. It is not just, don't take this if you have a cold. It effectively bans the drug for anyone with reactive airways. In the clinical trials, they found that 29% of asthma patients experienced bronchoconstriction and wheezing after a single dose.
Wow.
Yes, that is nearly 1 in 3 people gasping for air because they wanted to treat their blood sugar.
But we aren't talking about prescribing this to asthmatics. We are talking about patients with healthy lungs.
Even for them, there is a measurable biological price. The data shows a mean decline in FEV1. For those listening, FEV1 stands for forced expiratory volume in 1 second. It is basically a measure of how much air you can blast out of your lungs when you try your absolute hardest. It is the gold standard metric for lung health.
I want to be very precise about that data because it sounds scarier than it is. Yes, the label notes a decline. In clinical trials excluding patients with chronic lung disease, Afrezza-treated patients experienced a decline of about 40 milliliters more than the comparator group. But here's the key insight. That decline happened within the first 3 months and then stabilized. It plateaued. It did not continue to worsen over the 2 years of the study.
But it didn't reverse while they were on the drug either. You are asking a patient to accept a permanent reduction in lung capacity, however small, as the ticket price for using the drug. And that 40 milliliters is an average. Averages hide extremes. For some patients, the drop is significant. The FDA explicitly advises that if a patient has a decline of 20% or more in their lung function, you should consider stopping the drug. A 20% drop isn't just a statistic on a page. That is the difference between walking up a flight of stairs comfortably and getting winded at the top.
I think we have to weigh that against the reality of the alternative. We often talk about diabetes management as if every patient is perfectly compliant with injections. They aren't. For an insulin-naive patient or someone with a severe needle phobia, the barrier to treatment isn't a 40 milliliter drop in FEV1. It is the psychological barrier of the injection itself. If the choice is between no insulin and inhaled insulin, the risk-benefit analysis shifts dramatically.
Well, I am not convinced by the something is better than nothing argument, because it implies those are the only two choices. But let's stay on the physiology of the lungs for a moment, because this risk of bronchospasm isn't just a number. It changes the medical management of the patient entirely. The FDA requires spirometry, that lung function test, before you even start the drug, again after 6 months, and then annually. You're effectively turning a routine diabetes visit into a pulmonology visit.
That is prudent medical practice. We monitor kidneys for other drugs. We monitor the liver for statins. Monitoring the lungs is just the cost of doing business with this specific molecule.
It complicates the picture, though. Let me draw an analogy from the source material regarding Bruce Lee. Now, bear with me, because there is a very common misconception about inhalers that applies perfectly here. There has been historical speculation that an inhaler could have saved Bruce Lee when he died.
Ah, I recall that analysis. The fatal fluids theory regarding cerebral edema.
Exactly. The misconception is that an inhaler is some sort of magic wand for all breathing issues. But standard rescue inhalers like albuterol are beta-2 agonists. They specifically treat bronchospasm, the tightening of the airway muscles. They do absolutely nothing for cerebral edema or fluid imbalance in the brain, which is likely what killed Lee, potentially linked to hyponatremia or kidney dysfunction.
So your point is about the specificity of the treatment.
Precisely. Inhalers affect the lungs and airway specifically. If Afrezza triggers a bronchospasm, you have introduced a respiratory crisis on top of a metabolic one. You are complicating the patient's perfect storm, to borrow the phrase from the Lee analysis. You are taking a patient who needs to manage their sugar and giving them a potential breathing problem that requires a rescue inhaler. You are adding highly volatile variables to a system that is already fragile.
That is a fascinating parallel, but I would argue the Bruce Lee example actually supports my stance on screening. The reason Lee's situation was tragic, if we accept the hyponatremia theory, was a severe mismatch of physiology and treatment. With Afrezza, we have the tools to prevent that mismatch. In the study of patients without asthma, the rate of bronchospasm was 0%. Zero! The risk is confined to a specific population that we can easily identify and exclude. If we screen correctly, the perfect storm simply doesn't happen.
Identifying them is one thing. Managing them long-term is another. But let's pivot to efficacy. You mentioned the speed of the drug earlier. Does that speed actually translate to better control? Because looking at the clinical studies, I have to be honest, I just don't buy that it is better.
The data clearly supports non-inferiority. In the type 1 diabetes trial, section 14.2 of the prescribing info, if you want to check my homework, Afrezza plus basal insulin met the non-inferiority margin of 0.4% reduction in HbA1c compared to insulin aspart. In plain English, it works as well as the shots.
Non-inferiority is a statistical term, not a glowing endorsement. It means it wasn't significantly worse within a predefined margin of error. But if you look closer at Table 4, you see the cracks in the armor. In the insulin aspart group, the traditional injection group, 27.1% of patients achieved an HbA1c target of less than or equal to 7%. That 7% mark is the gold standard for control. Do you know what that number was for Afrezza?
It was lower, yes. It was 13.8%.
It wasn't just lower, it was half. 13.8% versus 27.1%. You are half as likely to hit the gold standard glycemic target using Afrezza compared to injections in that study. That is a massive trade-off. You are trading glycemic control for the convenience of not using a needle.
I see why you interpret the data that way, but you are looking at HbA1c, which is a 3-month average. An average creates a blur. It doesn't capture the daily quality of life or the time-action profile benefits. Because Afrezza leaves the system in 180 minutes, it heavily reduces the risk of stacking insulin.
Stacking?
Right. Stacking is when a patient takes a shot, checks their sugar an hour later, sees it is still high because the insulin hasn't fully peaked yet, and takes another shot. Then 3 hours later, both shots hit at once and they crash into severe hypoglycemia. Because Afrezza is in and out so fast, that risk is heavily mitigated. In the type 2 trial, severe hypoglycemia was very low, 1.7% in the Afrezza group. And speaking of type 2, look at Table 5. The HbA1c reduction was significant there, negative 0.82% compared to placebo.
Compared to placebo, that is an incredibly low bar. Of course, insulin works better than a powder without insulin. But my concern is that patients are being sold better control because of the rapid kinetics, but the trial outcomes for type 1 suggest they struggle to actually hit the targets. And I think a huge part of that struggle comes down to the dosing complexity.
Complexity? I mean, come on. It is a whistle. You put a cartridge in and inhale. It is easier than loading a dishwasher.
It is not that simple. The cartridges only come in 2 strains, 4 units, which are blue, and 8 units, which are green. Let's say a patient sits down to a large meal, maybe a pasta dinner, and needs 12 units. They have to load a blue, inhale, remove it, load a green, and inhale. If they need 24 units, that is 3 green cartridges, 3 separate inhalations for 1 single meal.
That is a mechanical inconvenience perhaps, but it takes seconds.
It introduces friction. And the conversion is not 1-to-1. You have to use a conversion chart to switch from injected units to Afrezza units because the absorption isn't the same. And the device itself, the instructions for use are very specific. You must keep the inhaler completely level. If you turn it upside down or shake it after loading, you lose drug powder. It is finicky.
I disagree that it is finicky. It is a medical device. It requires proper technique. Just like a syringe requires proper technique. Once the patient learns to snap the inhaler closed, which automatically opens the cartridge inside, it becomes second nature. And let's look at the broader context of inhalation therapies. Patients are already perfectly accustomed to this form factor. Look at Breo Ellipta or Spiriva Rest Mat. Millions of people manage one actuation once daily without issue.
That is a false equivalence, and you know it. Breo and Spiriva are for treating the lungs, COPD and asthma. You are putting the drug exactly where the disease is. It is a local treatment. Afrezza is using the lungs as a hallway to get to the blood. And the frequency is totally different. Breo is once a day. Afrezza is every time you eat. That is 3, 4, maybe 5 times a day. You are exposing your throat and lungs to this powder.
And yet, people persist with it. Why? Because the alternative is stabbing themselves.
But at what cost to their comfort? The adverse reaction data in Table 1 is telling. Cough was reported in roughly 27% of Afrezza patients. In the comparator group, 5.2%. Throat pain and irritation were also significantly higher. You are swapping a needle prick for a chronic cough and throat irritation. Imagine being at a business dinner. You inhale your insulin, and then you spend the next 5 minutes coughing at the table. For many, that is not an upgrade.
For some, it isn't. But for the 2.8% who discontinued due to cough in the trials, they can just switch back. For the others, the cough often diminishes over time. We cannot dismiss the psychological burden of injections.
There is a reason the medical community is still pursuing this. It represents a liberation from the paraphernalia of diabetes, the vials, the syringes, the alcohol swabs.
Well, I want to talk about the risks that go beyond a cough. We discussed the lungs, but the systemic exclusion criteria are broad. Smoking, for instance.
Granted, it is not recommended for smokers or those who have stopped within the last 6 months. The lungs need to be clean.
And the lung cancer signal. It is small, yes, 2 cases in the trials versus 0 in the comparators, but it was enough for the FDA to include it in the warnings and precautions. It explicitly says that in patients with a history of lung cancer, the benefit must outweigh the risk. That is a heavy conversation to have with a patient. Here, take this insulin. Oh, and by the way, we had a signal for lung cancer in the trials.
It is a necessary conversation, but context is everything here. Those cases were in former smokers. The data was simply insufficient to determine causality. We have to be very careful not to conflate a safety signal with a definitive cause.
There is also the diabetic ketoacidosis risk, or DKA. In the type 1 trials, DKA was more common in the Afrezza group, 0.43%, versus 0.14%. DKA is life-threatening. If this drug is faster and better, why are more people ending up in ketoacidosis?
That brings us back to the learning curve and the role of basal insulin. Afrezza is short-acting. It is only for mealtime. It does not replace the background long-acting insulin that type 1 patients absolutely need. The DKA cases often stem from patients failing to maintain that basal coverage or underdosing because they are not accounting for the shorter duration of action. That is an education issue, not a toxicity issue.
But if a drug requires perfect education and perfect adherence to avoid DKA and offers a lower probability of hitting HbA1c targets, the margin for error is razor thin. You are handing patients a race car when they might be safer in a sedan.
I would argue that we are moving toward a world where lung therapies are becoming more sophisticated, not less. Look at the recent approval of brensocatib for bronchiectasis. We are seeing the first FDA-approved medication specifically for that condition, targeting inflammation directly in the airways. The medical field is getting better at managing lung health and delivering complex molecules via respiratory pathways. Afrezza was a pioneer in this. Writing off the lung as a delivery route is short-sighted.
But again, brensocatib is treating bronchiectasis, a lung disease. It is treating the organ it touches. That makes intuitive sense. Using the alveolar surface area to absorb insulin is a biological hack. It works physically, but it treats the lungs as a utility rather than an organ. And when you look at the medication guide, the list of warnings, sudden lung problems, low potassium, heart failure risks with TZDs, it creates a complex matrix of risk that simply doesn't exist for a standard injection.
Every drug has a matrix of risk. Injectable insulin causes lipodystrophy, scarring of the fat tissue that can make insulin absorption erratic. It causes hypoglycemia. It carries the risk of infection at the injection site. We are just more comfortable with those risks because we have known them for 100 years. Afrezza offers a tool that matches the physiology of a meal spike in a way injected insulin struggles to do. For a patient who wants to eat a meal and have their insulin peak when the food peaks, at that 45 to 60-minute mark, Afrezza is uniquely capable.
That is the strongest argument for the kinetics. But you have to survive the delivery mechanism to enjoy the kinetics.
And most patients do, with proper screening.
Let's assume the patient is the perfect candidate. Non-smoker, no asthma, no COPD, good kidney function. They still have to deal with the practical reality of the device. You mentioned the snap. The instructions say you have to replace the inhaler every 15 days. You have to store the foil packages in the fridge, but then let them sit at room temperature for 10 minutes before use to avoid condensation or poor powder flow.
Is that really so hard?
The logistics of carrying foil strips, a bulky inhaler, and waiting for temperature equilibration. I mean, is that really more convenient than an insulin pen you can just keep in your pocket? An insulin pen doesn't need 10 minutes to warm up before lunch.
For someone who fears the needle, absolutely. 10 minutes of room temperature acclimation is a very small price to pay for not piercing your skin. And the blue and green coating is intuitive once you learn it. It is visual. It removes the need to dial a pen or draw from a vial. It simplifies the math for many.
I suppose we will have to agree to disagree on the definition of convenience. To me, convenience includes not coughing for minutes after every meal.
And to me, convenience is freedom from the anxiety of injection.
Well, we are coming to the end of our time, so let me summarize my position. The technology behind Afrezza, the technosphere particle, is undeniably impressive science. It is a triumph of chemistry, but biology is stubborn. The lungs are designed for air. When you introduce a powder, you invite inflammation, bronchospasm, and a decline in function. The data shows that while Afrezza is not inferior, it is significantly less likely to get patients to the HbA1c goal of 7% in type 1 diabetes. Combined with the coughing, the throat pain, and the rigorous requirement for spirometry testing, I believe this remains a niche product. It is an option, yes, but for the vast majority of patients, the biological price is simply too high.
And I maintain that we must look at the patient as a whole, not just a set of lungs. For the right patient, a non-smoker with healthy lungs who struggles with the daily burden of injections, Afrezza offers a liberation that cannot be undervalued. The rapid onset and clearance mimic the body's natural rhythms in a way that can prevent the dangerous lows of insulin stacking. The perfect storm of physiology determines the outcome. If we screen correctly, as you noted with the Bruce Lee case regarding hydration and kidney function, we can fully mitigate the risks. We shouldn't let the fear of the new prevent us from utilizing a valid, highly effective delivery route.
It certainly highlights that there is no free lunch in medicine. Every route of administration carries a cost.
Precisely. Whether that cost is paid in lung function or skin punctures is a choice the patient and doctor must make together.
For those listening, please do not make changes to your insulin regimen based on this discussion alone. Read the medication guide, specifically the sections on lung health, and consult your physician.
Thank you for listening to The Debate.